Hi, and welcome to the Dr. Coffee Podcast, your weekly blend of motivation, encouragement, education, and insight into all things medicine for junior doctors and medical students in South Africa. Welcome to episode 9, Coffee Beans. On this week's episode, I was privileged to grab a post-call coffee and spend time chatting with Dr. Vindana Chibabhai, a consultant clinical microbiologist at the National Health Laboratory Services at Charlotte Maxeke. Dr. Vindana is passionate about education and training of healthcare providers in all areas of microbiology, in keeping with her role as a lecturer at the Wits University Health Sciences campus. Dr. Vindana has a keen research interest in antimicrobial resistance, antimicrobial stewardship, healthcare-associated infections, and invasive fungal infections. Her interests led her to create the MICROBE MAIL podcast, a medical podcast for the busy practitioner or medical student covering topics in microbiology, infectious diseases, and infection control. Dr. Vindana will share more about her podcast, but I want to encourage every person listening to the Dr. Coffee podcast to follow and subscribe to the Microbe Mail podcast as well. You can find all of the important links and resources in the show notes to this episode. And with heaps of episodes and resources uploaded already, you're bound to find something that helps you to be a better clinician. That leads me to tell you about our sponsor for this episode, FlashMed SA. For this and other episodes, I'm pleased to announce that the Dr. Coffee podcast has partnered with FlashMed SA. FlashMed is a new type of medical study flashcard pre-packaged and formatted to assist you to be more effective as a student and ultimately help you to become a better doctor. Their pharmacology flashcards are the most efficient way to study pharms. On each card, you can write down the indications, contraindications, side effects, mechanism of action, and interactions of one or a whole class of medications. Memorize and quickly revise the most important information for each drug using the pharmacology flashcards for every exam. The flashcards are made of a thick, high-quality paper, which ensures that your cards remain in a good condition for years to come. The FlashMed revision sheet notepad is ideal for summarizing the most important aspects of a disease or medical condition, such as pathophysiology of the disease, how to diagnose it, the management and treatment, and how it presents clinically as well as its risk factors. It's ideal for quick referencing, brushing up on old knowledge, and studying for exams. The Muscle Anatomy Notepad is every anatomy student's dream. Muscle anatomy is notoriously difficult to study for, but these flashcards make it easy to compartmentalize and memorize the origin, insertion, innervation, and action of every muscle in the human body. The cards come in an A6 size notepad, also made of a thicker paper to endure many revision sessions. And for those in clinical rotations or even junior doctors wanting to save a little bit of time and add a professional polish to their patient clerks, the clerking sheet notepad is the best guide for a structured patient history, examination, systems review, differential diagnosis, and management plan. It is every clinical healthcare worker's best friend. The double-sided and pre-formatted form gives you a concise, structured approach and ensures that you don't miss out on any vital aspect of the patient's care, whether it's their social history, their vitals, or any of the systems under physical examination. Besides being great for patient care, the clerking sheet notepad is also perfect for OSCE practice. All FlashMed notepads are printed using the highest quality paper, and each set consists of 50 flashcards or pages. Made for students, by students, you can find FlashMed on Instagram at @FlashMedSA, all one word with no punctuation, and order direct from them via DM with nationwide delivery. I hope you enjoy using their products. Now, back to today's episode and our guest specialist, Dr. Vindana Chibabhai. We discussed her journey in medicine and the path to specializing as a clinical microbiologist. I learned a lot from our conversation, and I hope that you do as well. Without any further ado, here is Dr. Vindana Chibabhai. Welcome to the Dr. Coffee podcast, Dr. Vindana Chibabhai.
Hi, Simon. Thanks so much for having me.
It's a wonderful pleasure to have you today on the podcast. So, with all our guests, the very first question I ask them is where they graduated from medical school and where they did their junior doctor time.
So I'm a Witsie.
Hey.
I did my I call it undergraduate now because I'm past postgraduate.
Yes.
But I did my basic medical degree at Wits and I qualified in 2004. And junior time, I did my internship at Tupong and Klerksdorp Hospital Complex.
Okay, so Tupong is in Klerksdorp.
Yes. So Tupong is the hospital So it's very much like Helen Joseph and Rahima Musa.
Okay.
It's two separated hospitals. So it's Tshepong and Klerksdorp Hospital Complex. So shout out to anybody who's there this year. I remember my time fondly. And then at that time, we were one of the first groups. Well, firstly, we only had to do a year of internship then.
Oh.
So that was different from how it is now. And then the other thing is we were one of the first groups to do community service. So I had a year of community service, and I did that at Helen Joseph Hospital and Rahima Musa Hospital, which was also lovely. And then I did a year of just MO time in pediatrics at Rahima.
So I wasn't actually aware that it was as recent as that there was a change from 1 year of internship to 2. And you said that was also when they instated community service. So how did you feel during your undergraduate degree when they told you you're now going to do a community service year?
So angry, of course, because you're like, no, that's not what I signed up for. And I've already done 6 years of studying. And you're kind of looking at your whole life ahead of you and thinking that's a whole other year of my life that they're taking away from me. But actually, in the long run, the experience that you get during your internship and your community service is invaluable. You really can't explain, especially if you're going to be out on your own after that and managing patients by yourself. It's short. If you think about it, even those 2 years.
Was the year of internship as structured as the 2-year program now, where you have certain rotations that you have to go through for 3 months, others for 2 weeks?
Not so much, hey? So I remember that some of us, it depended on the hospital that you were at, and you didn't necessarily get to rotate through every single discipline during your year. It was a short year.
And probably also site dependent, right?
Yeah,
like if you had a greater surgical exposure, you did more time there.
Yeah. So certainly Klerksdorp and Tshepong was pretty good in that you had a pretty good overall through the bigger disciplines.
Okay. So when you were at medical school, were you part of any interesting clubs or societies? Did you do anything exciting? Any notable achievements? Any awards that you won?
No. So I was a pretty average student. I think I was one of those that worked too hard when I was in high school. So by the time I got to med school, I just wanted to get through medical school and enjoy the time that I was there.
Okay.
And socialize a little bit. I was also so scared of failing. So I worked hard when I had time to work hard. But no, I wasn't really part of any societies or,
So you did your internship 1 year and ComServe 1 year.
That's right.
And where to from there?
So as I said, I did 1 more year after that in pediatrics. That was MO time. And then after that, I got a registrar post in microbiology.
Wow, what a difference from pediatrics to microbiology. Why the switch? What's kind of sparked it for you?
So during both internship, community service, and my MO time, I was exposed to a lot of infectious diseases.
Being in peds, you would
Being in peds, you would be, exactly. And this was a time where ARVs was just coming in still. So a lot of the children didn't have access to ARVs. TB treatment was very different at the time. We didn't have pneumococcal vaccinations. So there was a lot of pneumococcal meningitis coming in with the kids. I also spent in those 2 years a lot of time in the HIV clinics. So it was really nice exposure to infectious diseases from that perspective as well. And so that's kind of where my interest and passion sort of grew from.
I can imagine that you kind of felt that you were at the cutting edge of a new frontier.
Absolutely.
And that's why it kind of sparked something for you. Was it like there was an expanding of opportunities that people were stepping into?
Not really. I must say the other MOs that I was with all wanted to do pediatrics. Whereas, although I was in pediatrics, I had more of an interest from the infectious diseases side. So looking back at the time, I thought, hey, I'm going to do microbiology and then I'm going to subspecialize in pediatric infectious diseases. That was the plan at that time. So although I loved peds, the micro side of it or the ID side of it kind of took over.
So if I read you correctly, it's almost like being exposed to microbiology in peds helps you to identify that this is actually where you wanted to go. And the lesson for any junior doctor or medical student is to be exposed to as much as they can, because that's how you will find what you are passionate about.
Exactly. And if you think you've got an interest and you don't get the exposure as a student, we're all quite open. I'm happy for someone to walk into the lab and say, no problem, I'll show you around. Come and spend a little bit of extra time if you've got in the lab, spend some time with our registrars. We're happy to have you here.
Wonderful. So we've touched a little bit on what microbiology is, but if you were to explain to somebody who has no understanding about what microbiology really is, or maybe to correct any misconceptions that you have encountered, what is the practice of clinical microbiology?
So the practice of clinical microbiology is from a diagnostic perspective.
Okay.
So as a clinician, you
And I hope I didn't misplace your role. Like I haven't pinned you into the wrong box.
No, not at all. So as a clinician, you suspect that your patient has an infection, but you need to prove this. So you'll be sending specimens to the laboratory. We will process those specimens and then we'll give you a result. So from a clinical microbiologist, we are different from the scientists and the technologists who we work very closely with. We're all part of the same team in the laboratory, but we're kind of that interface between pure laboratory diagnostics and the clinician who's managing the patient in the ward. So we understand the lab side of it, and that's a lot of what you do during your registrar time. You've got to learn how to process specimens in the lab. You've got to learn how to manage the laboratory as a whole. But then you understand the clinical side, which is why we're medical doctors first.
Yes.
You understand the infection, you understand the patient, you understand the antibiotics, etc. And we're kind of the string that ties the lab to the patient or the lab to the clinician.
So you can understand the question that the clinician is trying to answer.
Exactly.
And direct your lab techs to, oh, no, don't worry about that. I know where they're trying to go with this.
Exactly. So also understanding from the clinical side. So one of our big kind of pet peeves is that people don't put enough information on the laboratory request form.
Really?
So if you had written on there infective endocarditis, and I look at a plate in the lab and I say, hey, there's Staphylococcus aureus on this.
Yes.
I'll say, hang on, this is really important because they've said to me the patient's got infective endocarditis. I'll tell the registrars, go to that ward and see what's going on with the patient.
Wow.
So it's definitely getting kind of both sides of what's going on, tying it together. And I like to think of us as being detectives. We close the case is what we do for you.
How much of your time then would be patient-facing? Because you said you would send a registrar to the ward. So imagine that you do have some kind of interface with the patients.
Yeah. So that's one of the big misconceptions about microbiologists. People think that, we kind of hide in an office or we hide in the laboratory. And when I was thinking this morning, I was counting in my head how many ward rounds we have here at Charlotte as a microbiology department. We have 9 ward rounds in a 5-day week.
Wow.
So we have a lot of patient-facing interactions. Obviously, it's not directly with the patient themselves. It's through the clinician. But there are some days where we go up to 3 different wards on the same day and have 3 separate ward rounds. So there is, if you want to have a lot more patient-facing time, that's up to you.
That's really interesting.
Yeah. And there are other microbiology laboratories which may not be based in a hospital itself, and perhaps they might have less time in the wards themselves, but we like to have that clinical interaction here, and so we have quite a bit.
Do you ever get exposed to dangerous pathogens? Like, do you have to go and collect swabs from interesting places? And, you mentioned being a detective, and microbes are growing in all sorts of interesting places. Do you find that you have to go there like a detective and, lift the specimen from here?
So we're a clinical laboratory, which means that we only look at human samples, but there are other laboratories. So for example, at the medical school, there's a public health laboratory, but they also do the infection prevention and control audits. So when they do audits, they will go into an environment in a ward and perhaps swab certain settings, etc. I wouldn't necessarily say that that's dangerous work as such, but that, you need a specialized laboratory, which we do have as part of our complex, which is specifically for environmental specimen testing. We do get involved in some dangerous work because, about viral hemorrhagic fevers.
Yeah, so if let's say there was a suspected Lujo Lassa virus in the hospital, you would be the one on call so you can examine this rash and say, is this actually...
So we don't go to the patient themselves, but we're involved in the whole process from a diagnostic perspective.
Okay.
So there's a whole SOP in place about how the clinician dons and doffs their PPE, collects the specimen, and then there's a transfer from the clinician to the laboratory person who's also got to be donned in PPE. We will separate the specimens here, process whatever we need to here, and then send away specimens to the NICD or where, any reference laboratory that does that sort of thing. So, from our side, it's from the diagnostic perspective.
So would there be a lot of kind of overlap with somebody who's working in infectious diseases?
Absolutely. They're probably our best friends in the hospital. We talk to them every day. We also send them consults, where a clinician might be managing a patient and we think, hang on, they actually need to have a bit more help with this patient's management, and we'll call ID and say, please go and have a look at this patient. Okay. We have ward rounds with infectious diseases as well. And we go from ward to ward. So they might identify patients that are important for us to see. We identify patients we want their input as well. So they are besties.
So here's an opportunity for you to advertise. Okay. What is the best part of your job?
You're wanting me to pick something, Simon. That's a long list. We could be here all night. I really can't say that there's one specific thing. I love the detective work. I love the fact that we're solving puzzles every day. I've been qualified for over 10 years now. I can promise you there has not been a single day where I can say I was bored in microbiology.
Wow.
The bugs are always one step ahead of us. Really? As much as you think, okay, I've figured out Pseudomonas aeruginosa or I've figured out Staphylococcus aureus, they're one step ahead of us at every step of the way. They're evolving all the time. Things are changing. Then there's things like pandemics. We don't see those things coming. They kind of surprise you out of the blue. Even the VHFs, you never know when you're going to get one coming through. So definitely not boring. There's always new stuff changing, and I can't say that there's a limitless number of microbes that are actually out there. So even if you do think I know everything there is to know about E. coli, there might be a new pathogen that emerges. We know that Candida auris emerged only in the last 10 years or so. They've existed before.
Wow.
So it's not an opportunity to get bored.
That's really, really interesting. I never really thought of that. And so do you find that you have to be really, really well-read and well-versed on all of these bugs?
Yes, so that is something that you've got to do.
Do you have to be passionate about these microbes?
Absolutely, absolutely. But even if you're not, even if you're just passionate about a couple of them, your interest can grow just because of what you're exposed to on a day-to-day basis.
So within microbiology, are you saying that there are people who are like staph specialists?
Absolutely, yeah.
Wow.
So there will be a staph specialist. You have mycologists who love fungi and nothing else, and they only want to do mycology.
I was going to make a very bad joke about a fun guy.
A fun guy, but it doesn't matter because I'm a fun gal. Mycologists, there's parasitologists, there's a virologist who's purely virology as well.
I'm sure they were very busy during COVID.
They were, shame. Yeah. I'm glad we had a separate virology department and it wasn't our problem. But yes, if you really, really love a particular bug, you can absolutely go down that route.
That's fascinating. So what is the path to specialization? If somebody is listening to this podcast and they're saying, gosh, Dr. Vin's just hitting all the right notes and I'm really interested in following this and pursuing this as a career, what is the road to specialization in microbiology?
So as you would with any other medical specialty, you finish your basic MEBCH medical degree, you finish your internship community service, and then you've got to get a registrar post at any of the main universities in South Africa. It's the same as any other registrar time. It's about 4 years or so. And you write a college exam through the College of Medicine of South Africa at the end of that to qualify as a medical microbiologist.
Are there any kind of primaries or anything that you take before getting that reg post? Are there any courses that you would recommend somebody do?
So you can't really write your primaries before you're in a reg post, just because, remember, you're coming in as a clinician. You've been trained as a clinician.
Yeah.
And as I said earlier, you've got to learn how to process specimens on the bench. You've got to learn in depth about all of the microbes, all the antimicrobials, etc. And you need to have that hands-on exposure before you write your part 1. So there is an MEd part 1, which each of the universities has.
Perfect.
But you can only write that during your registrar time. You can't write that beforehand.
So does somebody need to learn lab techniques as a diploma? Do they need to get work exposure as an MO? How do they earn that right at the table, so to speak?
Mm-hmm. So at the moment, the problem is there's no MO posts in any of the pathology fields, including microbiology. But there are some community service posts through the NHLS. So if you are interested during your final year or in your internship year, find out about those posts. It's 1 year where you can rotate through any of the specialties that you feel you've got an interest in. So if you have an interest in microbiology and hematology, you can do 6 months in each rotation, decide which one of the two that you really like, and follow it that way. In terms of other courses, as I said, there's so many microbes out there, and they're all relevant. So there aren't specific courses, but there are quite a few TB courses. There's the HIV diploma.
I'm thinking of like the diploma of tropical medicine.
Yeah. So I was going to mention that one as well. So that's the diploma in tropical medicine and hygiene. The DTM&H is also on offer. There's quite a few antimicrobial stewardship courses available, some based at hospitals, others online. Any TB courses.
And those are only really courses you can do after you've completed internship, because you need to have an MP number to further your education, right?
Yes, exactly.
Okay. So if somebody had done those courses and they've done 6 months of MO time, what sorts of places will have reg time? You said all the major medical universities.
Right.
I imagine you wouldn't be able to do reg time out in, like, let's say, Gariep in rural Free State.
Unfortunately not. But remember, there's a laboratory anywhere you go.
Okay.
So say, for example, you in your community service time, find a laboratory and spend some time in that laboratory learning about microbiology while you're there, just to get some exposure. But the actual registrar time only at the big universities.
So besides having 9 ward rounds in a 5-day work week, what does a typical week look like for a microbiologist? How do you divide your time, and what are your responsibilities like?
So it's a busy day, and it's a full day. So unlike your clinical time where you do your ward work, and unless you're on cover, you kind of go home. Here, you're kind of here for the full day. You know, you're here at 7:30 or 8 o'clock in the morning, and you'll only leave at 4 or 4:30 in the afternoon. And there's a lot that we do. So the first thing is that we've got to check all of the benches in the laboratory for critical specimens or critical wards.
It's just define for our audience, what is a critical specimen or a critical ward?
So a critical specimen would be something like a blood culture, a cerebrospinal fluid, a tissue or fluid specimen that might have been collected from an ICU. So a critical ward would be an ICU, oncology, transplant units, those kinds.
I see. So it's more like the urgent cases that need your attention. They can't wait.
They can't wait, exactly. So we start our day looking at all of those specimens. And so the registrars will have from the registrar somebody who's allocated on blood cultures. And that person looks through all of the blood cultures. They check the plates, they check the cards, they check the susceptibility.
I thought that was all done by machines now.
No. So the technologists on the bench will read the plates, but so in the morning, the technologists will come into work. They'll pull out everything that's come out of the automated machines, but then they've got to marry that to the clinical case. So they take the cards, they take the ID, they take the ASD, and they put that together. And then we've got the registrar who will look at the two and say, does this make sense? Does it fit together? Is there anything I need to troubleshoot? Like, does something not make sense with this case? And they'll do all of that troubleshooting. And then like you would have a ward round in the wards, we have a blood culture bench round. So that's where the consultant will sit with the registrars. We'll go through all of those blood cultures that are significant from each ward. We'll have a discussion about them. We'll decide based on the clinical case scenario, based on the patient population, based on the organism, the antimicrobial susceptibility pattern that we're seeing, what are we going to recommend that they treat with?
So there's a lot more work that goes into putting out that lab track report that we get.
Yeah, then it looks like the surface. Wow. And then once we've had that blood culture around, the registrar will then communicate all of these critical results or significant results to the clinician, either by making a telephone call, having a discussion with you as a clinician on the phone, or we'll walk out to the wards and make a note in the file, depending on where you are and what the situation might be.
Wow.
So that's one aspect. Then remember, that's only blood cultures. We've got blood cultures, CSF specimens, stool specimens, pus, urine. What have I missed?
So is there a different person assigned to each different...
No, so we don't have that many people in the lab. We'd like to. There is on the benches. So each bench processes a sample type. But from the registrar side, they've got to split the work. So it's usually one person doing all of blood cultures, and then depending 1 or 2 other people who will do all the authorizing. So authorizing is taking each of those cases that are positive, looking at the organism, the susceptibility pattern, the patient population, the ward, and you then decide, I'm going to show the clinician amoxicillin for them to treat this particular specimen.
So I can imagine there's like little buzz points during the day when you discover some interesting cohort that's cultured somewhere. You're like, wow, I really didn't expect that. Do you have little eureka moments in the lab?
Oh, yeah, all the time.
Come look at what this culture is.
Exactly. Like stool bench. If we see a parasite, like the whole lab, everybody comes and looks under the microscope.
And half of the audience's stomach just turns at the thought
of a stool specimen. Let me change that.
With parasites writhing in.
Okay, you can delete that bit, Simon. If you see a fungi that we actually see under the microscope, everybody will have it together. Sure. So that's all the lab stuff, but that's only one component of the job.
Yeah.
Then there's, as I said, clinical ward rounds, where we have infectious diseases rounds, where we're interacting based on complicated infectious disease cases, or some of them are antimicrobial stewardship ward rounds. We will go bed to bed on anybody who's on antibiotics and discuss whether it's appropriate or not appropriate, and make suggestions on or recommendations on stopping or changing or whatever it might be. That's 2. 3 is lab management, as I said. As a laboratory, we have to subscribe to ISO standards on quality management systems. So the pathologists are always involved in that aspect of it. And then there's research. Things are changing, evolving all the time. We've got to make sure that we have our own local research outputs.
And not just generating research, but also following up on research. You know, there's a lot to read, I'm sure.
There's a lot to read. And my to-read list folder is probably bigger than any other folder. And it doesn't matter how much I'm reading, it just never gets any smaller.
On that takes me kind of down a little rabbit hole, because all of medicine, there's so much reading and there's burgeoning information all the time. Do you have any ways that you speed up your reading? Do you use any tools that you can recommend that make reading easier? Or do you find that you learn better by just sitting down and thoughtfully, word by word, reading through a document?
So I will read through an abstract first before I read through an entire paper. And I suppose I've read enough now that I can say I can skip through certain sections of a paper. So I often will not read the whole introduction. I'll just read what the aims are. The methodology, I feel, is quite important, because you need to interpret the results that you're reading in a paper. And then I always find the discussion very, very useful. So there'll be certain sections of a paper that I might skip through, but I will start with an abstract. And if I find that from the abstract certain things scream out to me that this is an important paper, then I'll continue reading. But I don't read every single paper from start to scratch. There just isn't time for that.
Okay.
And then if you're reading reviews, which I think a lot of the juniors would want to do, you may not read actual studies themselves, but you might be reading reviews. I think just look for reviews that are from really good journals, high-impact journals, so that you can trust the information that's in there.
Are there any microbiology journals that you would recommend, or any sources that you suggest that junior doctors stay up to date with?
So from the South African perspective, there's the Southern African Journal of Infectious Diseases. Really nice. There's lots of local data and lots of local publications. So a very good source of information there. They've also been publishing guidelines, and they're local guidelines. So, for example, the Candida auris diagnosis and treatment, which is specific to our setting, written by a group of South African experts. You'll find it in SAGID. Others would be the American Society of Microbiology. They've got a number of different journals, depending on, kind of what area you're looking at, whether it's antimicrobials or whether it's microbiology specifically. And then from a European perspective, there's ECMID, which is the European Society for Clinical Microbiology and Infectious Diseases. Their journal, they've got 2, clinical microbiology and infection would be one of them. The other is the European Journal of I don't know. She can't remember that one. Yeah, you know what?
It doesn't matter. So there's 2 journals.
Yeah. So there are quite a few journals, which are quite nice. On the FITSA website from South Africa, that's the Federation of Infectious Diseases Societies of South Africa, they've got quite a few links to where you might find important or useful information. And I also like listening to podcasts. So I think there's a lot of podcasts out there that you can listen to that give you good information.
And you missed a very good opportunity to promote your own podcast, which already has dozens of episodes. I was waiting for you to throw in there, the microbe mail podcast.
I was waiting for you to ask.
You do touch on a number of things, and you interview guests about clinical microbiology and beyond. Tell us a little bit more about microbe mail.
Okay, so because of the fact that I thought there is this huge lack of information from South Africa and generally the low middle income setting when it came to podcasts, I kind of had this light bulb moment sometime last year, and I said, now I'm starting my own podcast. So it's an educational podcast in microbiology and infectious diseases. It really deals with day-to-day issues that a clinician might encounter in your daily practice. And it's also kind of a conversational thing. So it's not overwhelming like listening to a webinar where it's very formal and get overwhelmed with information. It's 20 to 30 minutes long. I'm having a chat with another expert. We cover things that we have discovered clinicians have a problem with or medical students are struggling with.
I see.
So you don't feel at the end of the episode that you're completely overwhelmed. So the types of episodes we've had, source searching with Professor Guy Richards, which is excellent if you're trying to look for a source of sepsis in your patient. Professor Duzay has done everyday do's and don'ts in infection prevention and control. Things like, is this culture a contaminant?
So that's actually really practical.
Exactly.
That's not, I mean, initially I thought, oh, right, this sounds really theoretical, but there's implementation there. There's stuff that you can listen to an episode and go, oh, from now on, I'm going to do X, Y, Z.
Exactly. And then one of my favorite, more recent episodes, and we try and keep it light, as I said, is Goldilocks and the course of antibiotics. Not too short, not too long, just right. So we talk about the course of antibiotics and how long is long enough.
Yes, because antibiotic stewardship is obviously such an important topic right now.
Exactly. So it's available on any podcast platform anywhere in the world. So whether it's Apple, Google, Spotify, but MicroBioLogist also has a website. So if you want to, you can listen directly to the episodes on the website as well.
Excellent.
And so I've got a sign-up page on the website as well. And what's nice about signing up is I don't spam people. I don't have time to spam anyone. So you'll get an email when there's a new episode that's been released. And for each episode, I also create a little infographic, which is a summary of important information that was discussed in that episode, which is a nice little pocket guide that you can keep with you if you need to refer back.
That's amazing.
And you'll get those infographics if you sign up on the website.
That's fantastic. And I really hope the listeners take that opportunity to take that, push pause on this podcast, go over to Microbe Mail and avail yourself of that, because that sounds fantastic. It's clear that you have a passion for this and you want to educate, but also that you want to help people. So that's wonderful, and I'm only too happy to see that grow. I really hope that our listeners avail themselves of that. Now,
Simon,
I'm going to circle back
to
antibiotic stewardship,
right?
Because that's something that I've seen firsthand is important in the clinical space.
Exactly.
And are there new medications coming out? Because you said the bugs are always changing.
They are. So antimicrobial resistance is a huge problem, and it's actually one of my areas of interest from both a clinical perspective and a research perspective as well. So I do a lot of antimicrobial resistance and antimicrobial stewardship research. And the problem is that, the WHO said by 2050, 10 million people per year are going to be dying from antimicrobial resistance. But in 2019, they did a study, well, it was only published in January this year in The Lancet, which actually showed that in 2019 already, 1.2 million deaths were attributable to antimicrobial resistance, but 4.95 million deaths were associated with antimicrobial resistance. So it's a huger problem than we realize.
Thought at first.
Exactly. So we really need to get this message out. It is a massive, massive problem. From, I think, 54 or even more molecules that have been investigated over the last 15 years, only 7 of them have come into the clinical setting. In South Africa, this year, we're getting launches of 2 new gram-negative active agents, but we haven't for years.
Yeah,
I think probably at least the last 10 years, we haven't had new agents coming in. And the problem is that the new agents are very specific, so they're very niche. So it might only affect a very small group of isolates. They're not kind of big guns like when meropenem and imipenem were first launched, kind of treated everything.
Napalm.
Exactly. So the resistance is so severe at the moment that you have to, it's almost precision medicine if you think about it. Who's the right patient? Who's the right bug that you can give this one little antibiotic to? It's becoming very tricky, but more than tricky, it's scary.
I'm sure there's lots of content around this topic on your podcast, so I don't want to steal time away from that, because people should go to your Microbiology Mail podcast and listen. So let's talk about microbiology again. What are some of the pitfalls or negatives that you might have experienced through the course of specialization? Any hurdles that you've had to overcome in microbiology? Tell us about that.
So I think my registrar time was a long time away, so I'm not sure that I remember as clearly then, but I can give you some ideas from seeing registrars coming through now. And I think one of the biggest problems is that sometimes people come into the field thinking this is an easier specialization because you don't have those long overnight calls, and so you've got more sociable hours in terms of your work, but it's not in any way easy at all. As I said, again, you've got to know all the microbes, all the antimicrobials, all the syndromes, and you've got to know how each of these applies in the different patient populations. There isn't really leaving early because you've got so much of work to do for the whole day. So that, I think, is one of the biggest problems. So knowing how to juggle your time so that you are able to work a full day but still have enough time to go home and read. And you're going to have to use your weekends as much as you don't work as many nights and weekends as you would in a clinical setting. The point is that time is there for you to catch up on reading, etc.
So, Dr. Vin, if I was to ask you, what is your message to medical students and junior doctors about microbiology? What lasting impacts do you want to make on them through this podcast?
So I think one of the important things for everyone to understand is that microbiology is really important. And I don't know if that message gets across in medical school, and I don't know if that message gets across even in the clinical setting. If you think about it, Simon, there's hardly a discipline out there that escapes infections, right? Any discipline that you go into, you're going to see patients develop some or other kind of infection. So it's really important for your medical students listening to know that it's not something you should be brushing over. You probably in each discipline will see 30 to 40% of your patients seeing infections. So you need to understand the microbes, learn them well, learn your antibiotics well. And I mean, I understand that your time's limited as a student, but don't take what you're given by the lecturer at face value and say, well, this is all I need to learn. Go out there, read some more, add to your notes. And then at the end of the year, don't burn those notes. Keep them as reference.
Yes.
And then also refer back. So when you're in the clinical setting, when you're in the wards and you've got a patient with an E. coli UTI, go back to your notes, read about E. coli again, read about the antibiotic that you've had to give the patient. Because I promise you, as you go further along in your career, and you have less and less time to do that. So catch up when you've still got the time and when it's fresh in your mind. So for medical students, I think that's really, really important. And then for the junior staff, whether you go into microbiology as a career path or not, again, I think don't underestimate the importance of microbiology and where the world is going in terms of, one, climate change. We're going to be seeing pandemics rolling, over the next couple of decades. And I don't need to convince your listeners of that. It's been 2.5 years and the WHO has announced 2 pandemics, that of COVID and now the soon-to-be named monkeypox, renamed monkeypox pandemic.
It's going to be renamed?
Yeah, they're looking at a better name so that it doesn't prevent stigmatization, particularly for the African continent. That it might be associated with people coming from the African continent, as there was with the Omicron wave with COVID.
Yes,
they kind of blocked the borders, shut down for South Africa. So they're wanting to do something similar so that it's non-stigmatizing.
Okay.
So so climate change is coming. Antimicrobial resistance, we said, is a massive, massive problem. And also, again, as I said, the bugs are evolving all the time. You're going to need to know and you're going to need to keep up, whether you do microbiology or whether you go into some other discipline.
So what is some of the pet peeves that the microbiologists have? Like, are we collecting specimens wrongly? Like,
Yes.
The short answer, yes. Well, okay, what's the long answer?
The long answer is we have a lot of work to do together.
Yes.
And we understand that we shouldn't be working in our silo, and neither should clinicians. And it's something, everything requires teamwork. And we need to sort of bridge the gap. That's actually when the first episode on Microbe Mail is called Bridging the Gap between the bench and the bedside, and how we can interact better together for the patient's benefit. So starting from how you request the specimen, how you collect the specimen, how you get it to the laboratory, and from our side, how we communicate with you timelessly or process appropriately.
Wow, I love the alliteration as well. Bridging the gap between bed and bench. That's awesome. So what does the next 10 years hold for microbiology in general, or maybe within the South African context? If somebody wanted to start a career now in microbiology, what would it look like in 10 years' time?
So as I said, you're not going to be bored. We're expecting that there'll be more pandemics coming, and those are going to be surprises at any point. We can't really predict what's going to happen. Second, very exciting from a diagnostic perspective. There's a lot changing. Remember, for the last 100 years or so, we've been doing MCNS, and it's all been culture-based. But that's changing recently. There's a lot more molecular diagnostics that are available. We're even moving to sequencing for certain pathogens and certain clinical syndromes. And so you can imagine that there's going to be big data available for all of these things.
Now, that's not just viruses, that's also bacteria.
Bacteria as well. So we send fungi that we cannot identify through our normal phenotypic means for sequencing, so we can get the identification that way.
So they'd actually sequence genomes of all these different fungal species, and they could say, oh, it's within this genus and it's this subspecies. Wow.
Exactly.
Is that an expensive investigation?
It is expensive, but I think they're trying to build up capacity so we can offer it.
So what we might find in the next 10 years is that, like all technologies, it starts out expensive, but it gets cheaper and cheaper. So it'll become more commonplace to, instead of doing a microscopy culture and sensitivity and MCNS, because some people don't know what MCNS means, instead of growing something in a petri dish for 3 days, you're going to rather just sequence it because you can get a result in a couple of hours.
Exactly. So that's exactly what happened with TB, Simon. I think you and the listeners probably are too young to know that before we didn't have Gene Expert, we didn't have any PCR-based diagnostics for TB. It was all culture-based, and you had to wait the 6 weeks to get your result, where now the tables have turned.
And could you start, I mean, TB drugs have all kinds of side effects. So could you start TB treatment before you had the 6? Oh, okay.
Yes,
so
you
make
could
the clinical
start,
judgment, yeah.
But then you would have this long wait before you could confirm the diagnosis and all of the problems associated.
Okay, I was just thinking about all the ethical considerations of a possible DILI, drug-induced liver injury.
And not having a diagnosis.
Correct.
Exactly.
Okay, so that's some of the stuff. What else over the next 10 years?
Yeah, the other thing with diagnostics is that there's this move to laboratory automation, which is not new in the world. In fact, in the US and in Europe, a lot of the laboratories have total automation. In South Africa, the private laboratories have automation as well, but it's not something that's really taken off in the public sector yet. So if you could get to laboratory automation, that's another exciting change.
What are the strengths of automation and what are the weaknesses?
So the strength of automation would be that it functions 24 hours a day. It would be faster than manual processing. Also, the sad thing is that there are fewer and fewer people who are coming into the pathology fields or laboratory medicine as technologists and technicians. So we're constantly short-staffed, and we're straining the resources that we have in the lab by expecting a fewer number of people to process more and more samples. So you get away with that from automation. The cons of automation, typical with any kind of technology, you're going to have breakdowns, maintenance, electricity dependent, exactly, load shedding, the usual problems.
And how good is the technology? I mean, does a human eye need to come and kind of corroborate everything that's said? Or?
So they've got different systems available where you can have a pre-authorization session. So there's automated plate reading, for example. But you can go in as a technologist or as a pathologist and say, I'm just going to have a quick squiz through each of the plates, make sure nothing was missed.
Okay.
And that you would do digitally because it's all within the automated system.
So it's like the role of AI, in radiology, they speak about AI sifting through x-rays for the radiologist.
Exactly. Yeah. So there's a move towards that as well.
Okay. Anything else coming up in the next 10 years you can kind of predict, look into your crystal ball and think what might happen within microbiology?
So again, AMR is a huge thing. So lots of
AMR is?
Antimicrobial resistance and antimicrobial stewardship. As I said, the next 30 years are critical. So I see a lot of research in
That's
that
our
area.
generation, hey?
That's your generation. You guys are the guardians of the antibiotics, the few antibiotics that we have available that are working. So a lot of research, I think a lot of education, surveillance is coming in that field. And TB, HIV, malaria are still massive problems globally. So I still see a lot of work in those fields.
And specifically in South Africa and sub-Saharan Africa, I mean, that's the hotbed of TB, HIV, and malaria. And those are, if I remember correctly, are still within the top, certainly within the top 20, but maybe within the top 10 killers globally.
Yeah. Yeah. And add to that now the antimicrobial resistance as well, which is also a huge problem in sub-Saharan Africa.
Interesting. So there's actually a lot of work to be done.
There's a lot of work to be done.
There's a lot of space.
There will be work for microbiologists in the next 30 years, I can guarantee.
Fantastic. So we're reaching the concluding portion of this interview. Is there anything that I haven't covered, anything that you like just burning to get out there to our audience?
Yes. So microbiologists are lovely people. Okay. We are people. So just, if you're managing a patient and you're not sure, rather than thumb sucking and, doing the wrong thing, pick up the phone and give us a call. We're more than happy to have a chat with you about your patient, or take a walk and come down to the lab and come and have a face-to-face chat with us.
Is there a place for having a microbiologist on call in an internal medicine or a surgery department? Just having a number on the wall, like this is your microbiologist.
So there are call phones at all of the... Yes, and I know that the other major departments that have, the academic departments certainly, that have registrar rotations, they all have a call phone. So just find out what the call phone number is. If not, there are central laboratory phone numbers where you can actually phone the lab and ask to speak to someone.
Well, we've reached the end of this interview session for this podcast. Thank you so much for sacrificing your time to be with us, Dr. Vin. I think that the listeners have really gained benefits. I know I certainly have. My understanding of microbiology, not only as a clinical discipline, but also as something that we need to take seriously, even if we're not going to be microbiologists, has really been enriched, really been helped. I will tune into Microbe Mail, specifically about infection prevention and control. I think that's something that I've seen the importance of. So I'm going to start there and see what rabbit holes I go down. So thank you again for appearing on the Dr. Coffee podcast. It's been an absolute pleasure to have you on.
It was great to be here, Simon. Thank you so much for the invitation. I really appreciate it. And I appreciate the platform you've given to microbiology. I think there's a lot of people who don't know, and I hope more people learn about it through this podcast.
I do too.
And thanks for the platform in allowing me to talk about Microbe Mail as well.
Well, I hope you enjoyed this week's episode as much as I did. Full links to websites and resources mentioned can be found in the show notes for this episode. And don't forget to check out our sponsor, FlashMed SA. If you know of a consultant or senior registrar in a specialty that you would like featured on the Dr. Coffee podcast, please get in touch. The podcast's email address is drcoffeeza@gmail.com. That's drcoffeeza with no punctuation marks. We're also on Instagram and YouTube with the username @drcoffeeza. If you've got anything else on your mind, such as a request for additional topics, further information on how to engage with our guests, feedback on the show, or anything else, please get in touch. We'd love to hear from you.